Siddharth, can you hear me? Good evening, everyone. On the behalf of Team Dentistchannel Online, I would like to extend a very warm welcome to all of you to the second day of second virtual World Implant Expo 2021. Today, the topic, right now, the topic for the webinar is diabetes and dental implants, evidence-based approach by none other than Dr. Ashish Gupta. So before starting with the session, I have few housekeeping notes to make. If you have any doubts during the session, you can put your doubts and questions in the question and answer box, and each and every question will be taken up at the end of the session. If you have joined us from Facebook and YouTube Live, you can ask us questions by commenting, and we'll be answering each and every question at the end of the session. So without further ado, I would like to introduce our today's speaker to everyone. Dr. Gupta has graduated from DAV Dental College, Yamunanagar, and did his post-graduation in oral and maxillofacial surgery from GDC Ahmedabad. Presently, he is the professor and head of the department oral and maxillofacial surgery at Sudha Rasagi College of Dental Sciences and Research at Faridabad, and he is associated as maxillofacial surgeon with Sarvodaya Hospital and Shanti Devi Hospital, Faridabad. Over to you, sir.
Yeah. Good evening. Okay, can you see my slide now? Can you see the film?
Yes, sir.
Okay. So good evening, everyone. It's my pleasure to be speaking here, and it's all credit is to Dr. Aditi. She made me to speak here. And the topic which I'm speaking is little odd topic, but for me as an oral surgeon, this is a fantastic topic, and it is a topic which everyone should be aware of. It is diabetes and dental implants, whether we can do dental implants in diabetes or not. So how I will take this webinar further, it will be something introductory on implants, then something on diabetes, and then different aspect of diabetes on different tissues. For example, how diabetes affect the bone metabolism, how does it affect the periodontium, how does it affect the bone stability, how does it affect the bone formation. All those things we will be dealing with one by one. So my motto in surgery is that whatever you can do, you should do, but you should know where not to do the surgery. This is what we have been taught in our surgery lectures, in our post-graduation. So this is one thing where I would like to emphasize that in these cases, you must not try, or in these cases with this kind of arrangement you can do. So as you all are aware that dental implants are now one of the most important restorative methods, and success rate, everyone knows now, it goes up to 95%, and it can be up to 89-90% after 10 years. So this is an accepted treatment modality now. It is mainly because that there has been so many innovations in implantology. For example, there are different surfaces which are coming up or which have come up. There is design differences there, and there is a surgical protocol evolving every day. So success rate is increasing day by day. So it is getting to be one of the most important restorative modality nowadays. So once it is restored and it comes into function, there is the importance of everything. You know, you can put it in bone. Everybody can put it in bone, but your implant success is considered when it survives for a longer period of time. So that is because of functional demands. That is because of bone remodeling all around the implant. And that is why we consider 10-year success as success. So it can be, this failure can be due to many factors. But one of the factors which we are considering right now, I'm not going to go in details of factors affecting the implant survival. It is basically what we want to speak is we want to talk about the diabetes mellitus, which is a very controversial topic. When I started implantology in 2004, anything beyond HbA1c, anything beyond 7, we would not touch. But now it is getting different because of a lot of systematic reviews have come in and a lot of researches have been done. So we are seeing that it can be a little higher. So this is defined, diabetes mellitus is defined as a metabolic disorder of multiple etiologies characterized by chronic hyperglycemia, which disturbs the carbohydrate, fat, and protein metabolism, which may be due to insulin secretion deficiency, or maybe insulin action, or maybe both. It can be on the peripheral aspect, or it can be from the pancreas as well. So current WHO diagnostic criteria, very important for us, is that if it goes beyond 126 milligram per deciliter as a fasting sugar, or 200 milligram per deciliter as a RBS, or as 2 hours after the fasting sugar. So this is an important aspect, because you can consider if patient is having RBS around 200, so you can go ahead with the treatment modalities. Or it is a diabetic patient, but yes, with this kind of range, you can go ahead with your treatment. And if hemoglobin A1C, glycosylated hemoglobin, if it is more than 6.5, then we label these patients as diabetic patients. So it is type 1, type 2. You all know one is insulin dependent and one is non-insulin dependent or adult. It is mostly you will find type 2 diabetes. And why this topic is important is we have some 480 million or maybe around 500 million patients in India. So around 5 crore patients in India who are diabetic. So if statistically going, every 16 to 17 patient coming to your clinic would be diabetic. So we have to be very cautious about it. Otherwise, we might land up into trouble sometime. So hyperglycemia may adversely affect wound healing, periodontal health, and bone metabolism. So diabetes has long been considered a relative contraindication for dental implant therapy. It had been, and it is still. So we can have a proper blood glucose level or a very optimum glucose level where we can do our implantology as effectively as in a normal patient. So this is what we are going to see in coming slides in another 35-40 minutes. We will be seeing all these things, how diabetes affect the status and how we can take care of these things. And then at the end of our presentation, I would give you a few recommendations which are basically through the literature only. I have not made my recommendations. These are through the literature only. So pathophysiology, it inhibits cell proliferation and differentiation and extracellular matrix, which is produced, altering the osteogenesis related gene expression and protein synthesis. So in all, just to sum up in one sentence, that it affects all the cell proliferation and all osteoblastic activity by extracellular matrix production, reduction, and gene expression, protein synthesis, gene expression reduce. So it will be totally a system where diabetes can inhibit all sort of cell proliferation, and it may affect the osteoblast activity. What I would like to mention here is important aspect is that it doesn't increase the osteoclastic activity. It decreases the osteoblast activity. That means bone formation will be less, not the bone reduction will be more. So it is more bone formation defect than the bone destruction effect. it may have poor bone quality, but high bone mineral density. What does it mean? It means that in diabetic patients, you will not have a bone which is conducive for implant placement in some of the diabetic patients, but not in all. So bone metabolism, it has some effects on bone metabolism. As we see in the last slide, extracellular matrix formation around dental implant is inhibited, which is inhibited by advanced glycosylation end products, which are generated during irreversible molecular interaction with poor glycemic metabolites. So whatever poor glycemic metabolites are present, they cause these advanced glycosylation end products, and these products will be inhibiting the extracellular matrix formation around implants. This seems to be quite complicated, but it is not. Actually, these are at the level of tissues and at the level of cells. But yes, slow or a little bit of these things, they add up to a bigger thing, and then they will be having a bigger effect. They might have, see, every patient of yours is not going to be diabetic. Every diabetic patient is not going to be uncontrolled diabetic, and every uncontrolled patient who is uncontrolled diabetic is not going to have implant failure. But you must know the basic metabolism of the bone and how diabetes affect that metabolism. That is one thing which we need to concentrate on. So again, what we saw, that osteoblastic activity is suppressed and maturation is suppressed of osteoblast. So that will affect the bone remodeling, formation, and remineralization. Bone remodeling is one of the most important part once our implants are put to the forces or put to the action or put to the work. So that is very, very important for us to understand that it can affect the bone remodeling. So it may, another aspect of diabetes mellitus is that it can compromise the periodontal status. Another thing which is important in diabetes is that it reduces the immune response. So if immune response is reduced, you cannot reduce the number of bacteria around your implants. So implants will be subjected to bacterial load, but your immune response is lesser. So there is a chance of getting more peri-implantitis or post-surgical infection in the patients who are diabetic. But again, as we will go forward, we will see that it is all which story what we are building. It will be only for the uncontrolled diabetic. It is not going to be for the people who are keeping diabetes under control. So this is what we are going to see. After seeing all these risk factors and everything, but still there are few conditions, there are few chances where there is no option than implants. So implants are still beneficial, even if they have effect by the diabetes. So now to sum up, to sum up for bone metabolism, diabetes mellitus can lead to skeletal complications like fractures, osteoporosis, reduced bone formation, delayed bone healing, detrimental alteration in bone histomorphology at the level of electron microscopy and all. But we may have increased marrow porosity sometimes, poor mineralization, and less collagen production. So if I sum it up, it is a recipe for bone loss during the function. Bone metabolism, once our implant gets osseointegrated, then we don't need to do anything. But once this implant is under stresses, under forces, then we have importance of bone metabolism. So we will see it in few on further slides. So diabetes significantly aggravates the clinical symptoms in periodontal disease. This is what we know, because all periodontal disease is considered to be an immune-related thing. If your immune response is lesser, you have more periodontal disease. If your periodontal disease is more, then you have lesser immune response. So both of the things are there. So it can worsen gingival bleeding, increased attachment loss, deeper pocket depth, severe alveolar destruction in diabetes patients at all ages. So if it can affect the periodontium, which has an immune response of itself inside, then how it will affect the implant, where you do not have any periodontal ligament, you do not have any sort of saver cells, for example, polymorphonuclear sites. But in gingival crevice fluid, you have PMNs, but what happens to the implants? So if all these things are there and diabetes is not controlled, so there is no chance that there will be healing all around the implant, because there is no immune system of implant itself. So again, interaction of advanced glycation end products with its receptor will increase the inflammation. For example, what we saw, that what I talked about was the host response to local and systemic inflammation. So this is advanced glycation end products with the receptors, they join to each other and they cause local inflammation response, or they reduce the local inflammation response. And if your host response is not good, then systemic inflammation response will be little lesser. So there will be difficulty in getting inflammation controlled by itself. So you will have to work harder for that. You will have to do your scalings, root planings, or implant cleaning, or your removal of prosthesis and cleaning your periodontal area, and then putting your crowns again. So it will be a little tedious job for you if patient is not well controlled diabetic. So Golub et al. Observed in vivo a significant slower PMN response to chemotactic agents in gingival crevice. So that means this is what they're talking about is normal periodontium, not implants they are talking. So even in normal periodontium, it has been observed that there is a slower PMN response. So that means if there is any bacterial attack on the periodontium and patient is diabetic, which is not controlled, so there will be lesser PMN response that will not allow inflammation to settle down, or that will not help us to fight the inflammation. So if this scenario happens in normal periodontium, so how this will happen in implant? So this is what this is what I meant, that PMNs are present in crevice fluid. So, but in our scenario, in implant, there is no crevice, there is no gingival fluid. So if a periodontium can be affected in diabetic, then it will be affected in implant more, because there is no immune response of the tooth or itself. So another aspect is whether it affects the osseointegration of implant. It is the important part, because if it is not happening, or if osseointegration is not there, then that means your implant is failed. It is important for stability. It is important for inflammation-free survival. So if good osseointegration has taken place, so it will take more forces easily. It will not give up in the signs of, in the times of forces. It will not give up, and there will be no bone loss. So as we saw that there is a chance that diabetes will lead to impaired bone formation, delayed healing response, compromised bone quality. So overall, it will also reduce the osseointegration of implant to the bone. So, but if we have a good control on blood glucose, and in the time of healing, the time of putting implant, and in future also, if patient is keeping good health of his diabetes, then I think we will have a good osseointegration, and it will continue to be good. So another aspect is implant stability. Nothing has been found in a lot of studies in implant stability, but it is an important aspect You have seen that once we put implant, after 2 months, 3 months, or 4 months, according to your own protocols, you see how you put your, or how you load your implants. That is on your own protocols. But if we see, if glycosylated hemoglobin is more than 8%, so we have seen, or there have been studies where it has been shown that this implant stability will reduce. It reduces in all the cases. If you have put implant, it will be good stable for 2 weeks, and then it starts going down, your stability goes down, and then after 1.5 months it start picking up, and then primary and secondary stability comes into place. So it happens in all the implantology scene. But if hemoglobin HbA1c is more than 8, we see there is a bigger dip in implant stability in second to fourth week, and it takes a little longer time to get that secondary stability which we have in non-diabetic patient. So clinicians should be careful that in diabetic and non-diabetic patient, we should differentiate a little bit for the loading. If patient is diabetic, then we may take, or we must take a little more. For example, if I have a protocol of putting my implant or loading my implant at around 2.5 to 3 months in mandible, 4 months in maxilla, so I should take a month extra for both maxilla and mandible. Even if patient is having well-controlled diabetes, I would recommend you to go for 1 month extra. Tell that patient beforehand that you may have little bit of difficulty as you are a diabetic. Either you control it well, or we may have to load it after 6 months. So just give a patient an idea that you are going to take more time in this patient than other patients. So it should be explained to the patient. And then whenever I have seen, I was always bothered about duration of diabetes mellitus. People have generally asked me, why you want to ask about the duration of diabetes? Number one, most of the patient, they don't know when it started. But why it is important? It is important because if patient has a longer history, so we have more chances of complications. More chances of complication, because complication in diabetes happens at a microvascular level, or at the nerve level, or at the periodontal level. So if it is of a long duration, patient will be having very, very bad periodontal health, maybe having bad periodontal health, or there may be some microvascular diseases or microvascular problems at the cellular level. So we will have to adjust our treatment accordingly. We will have to train our patient accordingly. One of the studies by Olsen et al., they found that duration of diabetes was a statistically significant predictor of implant failure. All these studies are retrospective, or maybe very small sample size had been there. I have searched literature quite a bit. I could not find a lot of RCTs, that is randomized controlled trials, for this. But whatever we have got, so there is a chance that if it is of a longer duration diabetes, then there is a chance that it may cause implant failure. And you have seen, all are the dentists, you have seen that longer the duration of diabetes and more are the periodontal diseases. Two reasons which we have spoken already. One is your immune response goes down at the local and the systemic level. Another thing is that patients, if a patient is not a well-controlled diabetic, so that means that patient is not very much aware of the things. So we may have an unaware, or a patient who is not happy, or who is not doing the things what we want them to do. But there have been studies which say there is no problem. Implant survival is similar if it is for 2-year duration, or it is 2 to 5 year, 5 to 10 year, or more than 10 years of diabetes. But I will concentrate here, I will stress here, if patient is having longer duration of diabetes mellitus, we must take care of the patient. First of all, improve the periodontal health of this patient, improve diabetic status of this patient, make the patient healthier first, and then we go for our implant placement and loading of the implant. And if patient is less than 8 HbA1c, so we will be very happy with that, and we can go ahead with it as we go with the normal patients. So there should be some effect on bone quality also, as we have seen, we have talked about it. We see that there are D1, D2, D3, and D4 bones. So we know that D2 and D3 are the best bones. D2 is best, and then D3. It's a difficult scenario in D1 also, and it is a difficult scenario in D4 also. So this is what has been seen. Lower implant survival rates in diabetic patients for bone qualities 1 and 4. It happens in normal patients as well. Then we have mandible, more abundant cortical bone is there, so more chances of survival or more successful implantology in mandible as compared to maxilla because of bone density and bone formation. It is always there, but implants in the posterior region were shown to experience less bone loss than implants in the anterior region in diabetic patients. I don't have any explanation about it, but what I can feel is that there is more plaque deposition in the anterior areas, and there is more calculus formation in the anterior region, so more bacterial invasion in the anterior region, which causes this bone loss in anterior region. And all this seem to be affected by inconsistency in blood glucose level. What is more important to point out here is if a patient has 7.5 hemoglobin, glycosylated hemoglobin, and continuously this patient has 7.5, I'm not bothered about it. He's all right, or even 8. But a consistency should be there. It should not be 8 today, 10 after 3 months, 10 after 10 and a half after 3 months. So that means patient is not controlling the diabetes, and that is where our treatment is going to fail. So submerged implants seem to perform better than non-submerged implants. This is more or less a consensus now in the implants also. Submerged implants are better than the normal implants. So this is similar in diabetic as well as non-diabetic patient. So again, important aspect is how well the patient controls glycemia and oral hygiene will give us our success rate. So, effect on implant survival. When the success rate was analyzed by implant location, Funnel revealed that success rates for maxillar and mandible were 85.2, 85.7 respectively. That is, they are similar. But Arauzo Nobre et al. Showed higher survival rate, 98.1 in mandible, 92.5 in maxilla in a 5-year retrospective study. So this is again a consensus that 98 is around in mandible and 92, 93 in maxilla after 5 years, and its overall is around 95%. Anterior posterior, we have seen that anterior success rate is 83.5 and posterior is 85.6. Again, attributing to those factors, plus what I feel that there are more stresses on the posterior implants, and if prosthesis is well made and our forces are going in the right direction, so we may have good bone formation because of this stimulus. So that is one of the reasons that posteriorly it may have more success rate as compared to anterior. So do we have a different prosthetic phase or prosthetic considerations? It is same what I have spoken. if I do an implant exposure for the second stage after 12 weeks in one patient, which is a normal one, then I would do it after 4 weeks or 6 weeks in the diabetic patient. That is how we are going to see, because diabetes might have affected the osseous healing and osseointegration. Then we should not take a chance, because as we have seen implant stability gone down more than what goes in normal patients, and then it builds up. So we may, or we should wait for another 4 to 6 weeks before more than the normal patients, what we see. And again, we have to see the bone quantity or bone quality. This is important for immediate loading. If we want to immediately load this implant, then primary stability has to be more than 35, which we know, 35 Newton. This is what we know. But again, we have to see how the duration of diabetes is there. If it is a very long duration diabetes, then we must not go for a loading, immediate loading. We should wait, and we should do it in 2 stages. Again, wait for another 4 to 6 months and then do it. Again, what comes to the zero is that how the patient is keeping its glucose level, whether patient is having glucose control or not. That is what we have to see. But overall, if I have to do a patient which is a long-standing diabetic, so I would like to do a 2-stage procedure in that. There are 2 reasons for that. One reason, I do not know about the bone, how the bone is going to respond to this implant, number 1. Number 2, I want to see how patient takes up this implant treatment, whether patient is proactively supporting our treatment, or the patient is it's like everything doctor will do. So I see both the things, and then I take up the second stage. Surgical consideration. Again, surgical consideration is whether we should put it immediately, whether we should put it later. These are a few questions to be asked in surgical consideration. For example, when to put it. Either we put it immediate, or we should put it early, or we should put it as delayed. So this is how we answer these questions. Another is whether it should be flapless or it can be a surgery with flap. These are the 2 questions which we need to answer in surgical considerations. So if patient is having hemoglobin or glycosylated hemoglobin level less than 8, and if patient is having good glycemic control, still that patient may have lesser bone loss in cases where implants are placed in delayed sense. So I can attribute this to the reason that in extraction sockets, if we put an implant, so there are 2 kind of healing going on. One is going on in the socket, and another goes around the implant. And as the patient is diabetic, so there will be less bone formation, there will be less extracellular matrix formation. So there are chances that there will be little bone loss in those cases. So we must take care, and we must put these patients on implants after certain time of healing. When we are sure about the bone, then we should go in these patients. This is a long-term retrospective study which is done, 8.7 year study, 169 patients with HbA1c level less than 8%, categorized into 3 different insertion protocols: immediate, early, and delayed. And you see that there is less bone loss and higher implant survival in delayed insertion group. Then implant choices. Do we have different implant choices for diabetic patient? Not really, but yes, if a patient is having single crowns, so we may use shorter implants. Especially in the diameters, we can use shorter implants. The reason is very simple. We should have more bone around the implant. So if we have around 7 millimeter of bone, so we should not go more than 4 millimeter of implant diameter, so that we have 1.5 on all the sides, and we have good bone which will be supporting the implant. So if bone is lesser, there are more chances of bone loss. So we should use smaller implants or shorter implants. And if we have to use overdentures, we may use longer implants. No explanations as such, but yes, you should have more bone around the implant in diabetic patients, more than in normal patients. You should have more in diabetic patients. Nowadays, sandblasted large grade acid or hydroxyapatite surface are effective, and they are good even in poorly glycemic control patients. So we do not have to worry about much about the surfaces. We should not give more weightage to the surfaces. We should not listen to the implant companies. Oh, this surface is that, this surface is that. Don't worry about it. See the bone, see the tissues, see how the patient is dealing with the diabetes, and go ahead with your treatment. But yes, delayed placement and delayed loading, it should be there. Okay. Then surgical procedure, flap or flapless surgery they exhibit similar peri-implant clinical bone loss. It happens with all the time. Even in normal patients, if you raise a flap, you will have a little bone loss as compared to without flap raising surgeries. So I don't think diabetes should be restricting the use of full thickness flap or flapless technique. It should be your choice. It should be your expertise. Whatever is comfortable in your hands, you do it, whether it is a flapless surgery or it is a flapped surgery. So don't worry about it. Go ahead with your choice, whatever you want to go for. Another aspect which I had been dreaded always was how diabetics will take care of, or how diabetics will see bone augmentation. Nowadays, as the implantology is growing, so we have a lot of uh, bone augmentations. We tend to take more bone augmentations nowadays. So is it important for us to know whether bone augmentation should be done in the implant patient or not? So for that, a clinical study enrolled 12 well to moderately controlled, that means less than 7.5 glycosylated hemoglobin type 2 diabetes patients, and same number and control patients. So that means totally 24 patients. And they have staged GBR implant surgery using bone graft materials, autogenous bone, anterior premolar region with horizontal bone defects. So there is horizontal width gain as it is in normal patient. So we are not worried about it. But again, the aspect is how patient is controlling its diabetes. So if there is a good glycemic control, see the patient first, observe this patient for some time, see how patient is aware about the glycemic control, how patient is taking up diabetes, then we can go ahead with the bone grafting. But we have studies where there is failure of bone graft due to uncontrolled diabetes or due to increased glycemia or hyperglycemia. Otherwise, if patient is having good glycemic control, we can go for vertical as well as horizontal bone augmentation easily. So next aspect is peri-implant health. Peri-implant mucositis may be identified clinically by redness and swelling of the soft tissues. Bleeding on is currently recognized as the important feature. So key parameter for diagnosis of peri-implant mucositis is bleeding on gentle probing. Peri-implantitis is characterized by change in the level of crestal bone in conjunction with bleeding on probing, with or without concomitant deepening of peri-implant pockets. So if there is a peri-implant bleeding, we consider it as to be peri-implant mucositis. And if it is showing some crestal bone loss also. It is called or considered as periimplantitis. Poor oral hygiene plus poor diabetes control will cause more periimplantitis as compared to normal patients. So what we do, if in normal patients, I call my recall my patient after every year to show me. But in these patients or in diabetic patient, I would call the patient after every 5 to 6 months. This is recommended by Monnier et al. And we should do scaling or root planing or removing the plaque and local bacteria colonies to be reduced. And this is very important in diabetes mellitus, that we must take care of the peri-implant tissues better or well. And this will reduce the chances of peri-implantitis or peri-mucositis. So are antiseptic mouth rinses important for us? Yes. To facilitate plaque control and prevent post-surgical infection, we must use 0.12% of chlorhexidine 2 weeks initially, but always we should use at least once in a day, we must use 0.12% of chlorhexidine in type 2 diabetes patients. That reduces the failure by 9.1% in a study by Morris. So it is recommended that we must ask patient to use antiseptic mouthwashes during the surgical phase, during the healing phase, as well as in the longer run also. Prophylactic antibiotics, we must use prophylactic antibiotics in the diabetic patients because they have lower immune response. So there are more chances of getting infection. So we must use prophylactic antibiotics like amoxicillin, clindamycin, or metronidazole if patients are allergic to penicillin. Prophylactic antibiotics should be used always. So during surgery and after surgery, you must prescribe prophylactic antibiotics. And if you have a surgery which is having more number of implants, or which is having more surgical procedure, for example, indirect sinus lift or the guided bone regeneration surgery you are doing along with the implants. So we must use one antibiotic 1 hour pre-operatively, intravenous. We should give it, and it reduces the potential infections in these patients. So 1 hour pre-operatively, you must give one antibiotic shot 1 hour before that. So we will see a few studies. I have collected studies from 2011 onwards. It is like a 10-year plethora only, because previously the sample sizes were very less, and even the follow-up periods were not too great. It was like 6 months, 1 year, or 2 years per there. So one study, which is Khandelwal et al. In 2011, it's a prospective study. Successful implant therapy in patients suffering poorly controlled diabetes. No difference between the two implant systems. Here we come that surfaces, if it is a conventional SLA implant or it is a chemically modified SLA, there is no difference between these two sort of implants. So what I mean to say here is that any surface is good surface. We must use a better surgical protocol, good diabetic control, and proper sterilization, asepsis technique. I don't see any sort of problem in putting implants in diabetic patients until and unless patient is very poorly controlled. So another study, again done in India, Inbarajan from Ramchandra University, Chennai. Dental implants can remain functionally stable in patients with well-controlled type 2 diabetes mellitus. More or less, the things are coming to the same, that they are going to remain functionally stable in well-controlled diabetes mellitus. So another study in 2014, diabetes does not have any influence on implant survival after 8 years. Another study in 2014, Erdogan, he's done a lot of work on this. So no significant difference for wound healing, radiographic findings. Another study, Moreno, they studied elevated HbA1c causes more bone loss, but not very significant. Erdogan, again, stage-guided bone regeneration is feasible augmentation procedure, no issues in that. Dental implants and diabetes mellitus by Naujikar, very good article. You can go ahead and see this article. Poorly controlled diabetes, they may suffer from impaired osseointegration, elevated risk of periimplantitis, and higher level of implant failure. Another study, patients with diabetes can receive implant-based treatment provided they present moderate HbA1c values. Cross-sectional study, implant survival rate is similar to the non-diabetic patient. Oral hygiene maintenance reduce hyperglycemia and peri-implant inflammatory parameters around immediately loaded dental implants. So very, very important importance is for oral hygiene maintenance. So implant stability initial is lower, but after 1 year, there is no difference between poorly controlled and well controlled. This study in 2016, it says that patient has functionally stable who are having well-controlled diabetes. Very good systematic review in International Journal of Oral Maxillofacial Surgery. The number of implant failure does not differ much between diabetic and non-diabetic subjects, but it is to be a more controlled study. So another thing, randomized control trial, type 2 diabetes patients' level of crestal bone loss around dental implant placed following flap surgery was comparable to flapless. So few studies more, meta-analysis detected the risk of periimplantitis was around 50% higher in diabetes than non-diabetics. So 2021 latest systematic review, it results of bleeding around dental implants suggested that as HbA1c level increases, the bleeding of tissue surrounding the implant will also increase. So we must take care of good oral hygiene. In another review, it says that type 2 diabetes does not seem to be a risk factor for immediately loaded implants. So we have talked about it already. So another study, survival rate by conventional and flapless technique is similar. So we had conducted one study in 30 patients, which are 15 were diabetic, 15 were non-diabetic. So what we found that if it is beyond 7.5 to 8, we have seen some bone losses. This is one case where we had put one implant later, and this is after a year, we see some bone loss here, and this is a diabetic patient. Another patient, 3 implants placed, loaded. So there is some bone loss present. Another diabetic patient. These are uncontrolled diabetic patients, which I am showing you. One patient, it's like 2 implants placed, impressions, loaded. So there is bone loss. It may be attributed to prosthesis failure, or it may be attributed to less proper oral hygiene by these patients. So hemoglobin, blood glucose treatment is there. If HbA1c is less than 6, don't worry about it. Go ahead with it. If it is low to medium, that is 6 to 7. So just see that the patient has higher controlled HbA1c, or medical consultation should be there, because these patients may have some other complications of diabetes. If medium to high, no chances, just go for a medical consultation. If more than 8, definitely send it to medicine people and get a better glycemic control before we go ahead with this implantology. So evidence-based recommendation, what take-home messages are there? It is monitoring blood glucose level is of primary importance. This is what I'm telling you from the first slide to this slide. Patients with HbA1c less than 8% are suitable for implant therapy. This is by the evidences. I have not deduced this, but as we have seen the literature, if it is more than 8, we should not put it there. Patient with poor glycemic control should be informed that they are more at risk for implant failure. Check for patient's periodontal status, oral hygiene, and history of periodontitis. We have spoken about it. Make sure that periodontitis is under control. Biannual periodontal maintenance therapy is essential to keep peri-implant health and ensure long-term implant functioning. Of course, we have seen prophylactic antibiotics and antiseptic mouthwashes as adjunctive therapy should be there to prevent post-operative infection and later on to reduce the bone loss. Delayed implant insertion favors the preservation of peri-implant marginal bone. Very, very important aspect. Kindly make sure that you are doing most of them as a delayed implant insertion. Implant surfaces is okay, but yes, as the implant surfaces are evolving, so you must use SLA and SLA active implants nowadays for better implant survival. Bone grafting techniques are feasible easily, but we should not be overzealous. We should control the blood glucose level. We should see these patients, and we should use uttermost antiseptic or sterilization techniques to use. Immediate loading protocol can be applied to vein-controlled diabetics, while conventional loading is more suitable for purely controlled diabetics. These are few references what we have. I hope it would be an important aspect for all of you to see a diabetic patient, how you should take care of that diabetic patient. Diabetic patients are different from the normal individuals, normal patients. We must be very particular about the hyperglycemia, or we must be very particular about the glycemic control. Everything will settle down if we have a good patient who can have a good glycemic control, especially in the early phase of healing, and then at the time when loading is more. And all things sum up to a good surgical protocol along with a fantastic prosthodontic planning will survive most of the implants in most of the people. Thank you so much, ladies and gentlemen, for your patience listening.
Thank you so much, sir, for this amazing webinar. I'm sure each and every person would have got their all the doubts cleared. So before starting with the question and answer session, I request all the participants to kindly drop their questions in the question and answer box so that we can take up one by one. And before moving on to the question and answer session, sir, I would like to seek your permission so that I can share one. I can introduce our company to the participants.
Please go ahead.
Ji. Okay. So this is our organization, Dentistchannel Online, with the motto "Healthy Smiles that leads to wealthy lives." And this is our second chapter of Virtual World Implant Expo 2021. In 2020, we had the first chapter, and it had been recorded in the India Book of Records as well. So these are the stalwarts of implantology that we are having this time. So quickly, I'll just introduce our organization. Dentistchannel Online Pvt Ltd is a dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinars and courses on different areas of dentistry. Being a prime member of Dentistchannel Online brings you several opportunities, accredited webinars, and dental courses. So we conduct more than 10 or 15 webinars every month, and we conduct a lot of workshops. So I request all the participants, whoever are watching, to kindly subscribe to our prime membership so that you get added benefits. You'll be getting certificates for each and every webinar that you attend. You'll be getting a certificate for this Implant Expo as well. And that will be accredited with 30 CPD points. So be a prime member right now. And this is one sample certification that we'll be receiving after the completion of the Implant Expo. So the last but not the least webinar of the day is by Dr. Shaukat Ali on new age tools, tips and tricks of dental implantology starting at 8 p.m. So keep watching and keep following us. You can visit our website www.worldimplantexpo.com. And I request all the participants to kindly take a screenshot of the slide and save this number and send your name as a text message on this number so that you're added on the broadcast list of the organization, and you will be updated regarding each and every upcoming webinars that we are having. Webinars, workshops, events, whatever event it would be, you will be updated regarding each and every event. So I request all the participants to kindly take a screenshot and save this number. These are the sponsors for our event. And for all the recorded videos, if you have missed out our live session, you can watch us. You can watch the recorded videos on Facebook and YouTube. So you can follow. So I request you to follow us on Facebook, Instagram, and YouTube. And on Instagram, you'll be getting all the updates regarding each and every event. So now there is one small video. Okay. So, sir, should we start with the question and answer session now?
Yeah, I can take up a few questions.
Ji. So first question is from Dr. Yash Kumar. He's asking on 6 monthly follow-up, if required, can we do scaling directly on implant surface if it is exposed?
Yes, you can do, but generally what we see or we do is the surface which is exposed. We should make that surface less rough. For example, we can grind that surface with the air rotor bar, diamond grit, and so that it doesn't accumulate too much of plaque or calculus later on. And you can do it straight away, yes.
Okay. Moving on to the next question. This is by Dr. Iftikhar. Aren't we supposed to use special plastic scaler tips to clean around the implants?
Yes, either plastic scaler tips or the titanium scaler tips. You can use any of those.
Right. So before ending the session, sir, any takeaway note for all the participants?
Take diabetes seriously. If your patients are diabetic, for any dental treatment, take diabetes very seriously. And you are the one who can motivate people to control diabetes. I have seen so many patients whom I have diagnosed diabetes for them. A patient 45, 50 years, poor oral hygiene, poor periodontal status. So I would request them to go and get their sugar checked, and they come out to be diabetic. So dentist can be a big help in diagnosing as well as motivating people to control diabetes. Thank you so much.
Thank you so much, sir, for being with us, for taking out time for us from your busy schedule. And the session was amazing. And this will be like a big lesson for all the dentists and all the practitioners. And thank you so much for being with us.
Aditi, I will request you a genuine feedback on my WhatsApp.
Yes, absolutely, sir.
Yeah.
With this, thank you so much to all the participants for being with us. And with this, we are ending the session. Thank you and have a great evening ahead.
Thank you.